So we're going to allow people to continue to filter in. I know that our keynote just wrapped up. So I expect that there will continue to be some folks who are going to filter in over the next couple of minutes here, but I'm going to go ahead and get us started and respect out of everyone's time. So thank you everybody for being here, and thank you for attending the 2024 Symposium on Substance Use Research. My name is Tierney Lorenz. I am an associate professor of psychology and in the Center for Brain Biology and Behavior, as well as the Radar Center that is one of the hosts of this year's symposium. I'm joined here by my co-moderator, Katie Bogan. Katie, if you would introduce yourself, please.
Absolutely. Hello, y'all. My name is Katie Bogan, she, her pronouns. I'm a fifth-year doctoral student in clinical psychology, working in the clinical psych training program. And I work with Dr. Tierney Lorenz and David DeLillo at the intersections of sexual violence and sexual functioning research. So I'm really delighted to be here with you all this morning in community, in active community.
Yeah. And we are very, very pleased to get to have a space to talk through women's health research, which is always a topic of extraordinary importance, but I feel like everyone on this call today is feeling that particularly this morning, the importance of creating space to really focus in on women and gender diverse people. So that's what we're going to be talking about today. A few reminders before we get started. The session is being recorded. We will send an email to registrants and post on social media when the recording is available. Note to our attendees, this is a webinar, so attendees are muted, but we encourage you to drop your questions into the Q&A, which you should be able to find at the bottom of your screen. Rather than a chat, you should be able to use the Q&A to submit questions, and we will be taking questions as time allows. So I'm very excited to be able to introduce our incredible panelists today. We have three experts joining us from a range of different disciplines, all of whom focus in on women's health and substance use research, but from very different angles. So I'm going to ask each of our panelists to introduce themselves, starting with Lauren Colley.
Hi, everyone. Can you hear me?
Yes, thank you.
Yeah. Okay, good. My name is Lauren Michelizzi. I'm an assistant professor at Brown University School of Public Health. I'm in the Center for Alcohol and Addiction Studies. And I, most pertinent to this conversation, study the etiology and treatment of maternal substance use around the perinatal period, recognizing generational transmission of risk and resilience and thinking about how substance use impacts the parent-child relationship. Thanks for having me.
Thank you so much. And Danielle Davidoff.
Hi, everyone. Can you hear me?
We can hear you great. Thank you.
Great. I'm Danielle. I'm an associate professor in the School of Public Health at West Virginia University. And my research is mostly qualitative and mixed methods, patient-centered and survivor-centered research as I work in the field of intimate partner violence mostly, and then the overlap and intersection with substance abuse and mental health, mostly among rural populations. And so I'm really excited to be here today and talk with everyone about what's happening in the field. So thanks for having me.
Fantastic. And rounding out our panel, we have Kiana Brown.
Yes. Hello, everyone. Thank you for having me. My name is Dr. Kiana Brown. I'm an assistant professor at the Rutgers University School of Social Work, and I am a drug dependence epidemiologist, a clinical and translational scientist, but overall, I view myself as a scientist practitioner. I come to this discussion having formerly been an Army nurse. I am a licensed social worker and a scientist. So I've also worked in the community. So as I talk today, I like for you to keep in mind all of the different perspectives that might be informing my answers, not just from a purely scientific perspective or purely practitioner perspective or purely community advocate or community organizer perspective, but all of those things in one as I approach my research and practice in substance use and maternal and child health from an health equity lens.
Thank you so much, panelists, for your introductions and for being here. So just as an orientation to our attendees, we have a few what we're calling breadth questions that we're going to be asking of the whole panel. Each panelist will have about 2 to 3 minutes to discuss their perspectives on these questions, and then we'll have a little bit of free flow after each of the after all 3 panelists have had a chance to speak. And then following the breadth questions, we have some quote unquote depth questions, which each of the panelists has chosen their own. So each will have a little bit more time to talk about their thoughts on that topic, but have the other panelists jump in. And so we will, as I said, take questions periodically throughout if you can drop them into the chat. So our very first breadth question here, kind of taking things very broadly. Given each of your individual areas of expertise, what do you think are the most pressing gaps at the intersection of women's health and substance use literature, and what populations are underrepresented in those areas? So just starting on the top of my screen here, Lauren, if you want to take us away on that.
Yeah, I'm happy to. And thanks for the thoughtful question, Tierney. I see a really pressing need to understand sort of the motives and effects of substance use during critical life stages for women, particularly around pregnancy, postpartum. And then, this is really new to me, but an area I'm excited about is getting into the menopause space, where we see, really distinct changes, significant changes in the physiological functioning and psychological functioning of women. I also see, in my work, I'm focusing quite a lot on the intersection between substance use and maternal mental health, and specifically as it relates to, symptoms of depression and anxiety, and the overlap with cannabis use in pregnancy. And I'm seeing a real lack of sort of prospective data on the relationship between substance use and maternal mental health around the perinatal space. And this is particularly relevant to cannabis use, specifically given that it's growing in prevalence. And, when we talk to pregnant people who use cannabis, they're reporting that they're using it to manage their mental health symptoms. And so this signals to me that we need to sort of do better at thinking about how to, help pregnant people think about cannabis use to manage their mental health symptoms. That extends to other substances as well. And sort of offer, supportive, non-stigmatizing infrastructure to these people to make healthy decisions. And I think, in addressing that gap in particular, we can design effective, equitable interventions that are tailored to, the unique needs of women's health at, critical transitions in the lifespan.
Fantastic. I know right now cannabis is high in my mind because we just had the ballot referendum here in Nebraska that is, assuming that there aren't legal challenges, likely to make Nebraska one of the states in which we have medical marijuana. And I believe that as of this last election cycle, there are now more states that have access to at least medical marijuana than don't. And so we really are at a national tipping point in terms of the access to cannabis and the need for better research, particularly in the context of, as you were saying, mental health symptoms, people using cannabis to manage mental health symptoms, but at the same time, we know can potentially contribute to mental health symptoms in a very complicated way. So I'm echoing that for you. Thank you, Lauren. Danielle, same question. Given your area of expertise, what do you think are the most pressing gaps at the intersection of women's health and substance use research?
Sure, thank you. So as I said, I do work mostly in rural populations, and I am in West Virginia. So as most of you likely know, we're really in many ways the epicenter of opioid epidemic and substance use epidemics really over the last over the last decade. And we lead the nation and have led it for a while in drug overdose deaths as well. And so where I see some real gaps are in, translating what we know in terms of things like intervention, prevention, especially related to harm reduction. We've had some really difficult times trying to implement harm reduction programs in our state. And there have been some times where we actually had momentum, funding, and we had a few harm reduction clinics and needle exchange clinics set up in various parts of our state. And I want to say over the last 5 years or so more recently, there has been really an uproar about that. And folks have actually taken action to get those harm reduction clinics closed down. And I think in all but maybe one case, they've been successful in doing that. So I think related to the public's perception of harm reduction as, a public health issue, as a way to reduce morbidity and mortality, I feel like we have a long way to go, at least in rural areas, with promoting harm reduction and the importance of it, what it is, because there's certainly that sense that if we in any way provide harm reduction strategies, techniques, information, that we are condoning it, and there's a lot of resistance about that here. And so it feels like that should be something that 10 years ago was the issue, but it is very much the issue here right now. So that's something that I would really like to see some more, maybe on the ground, grassroots research doing. It's very possible that in academia and in our silos, we are just not translating what harm reduction means to the public. And so that might be an area where we could do a little bit better. So thank you.
Thank you for that. Yeah, as you're speaking, and I'm also thinking about what Lauren was saying about perinatal and prenatal care. I think my impression of the field of women's health within the context of substance use is that historically, at least, so much research on women and substance use has been really focused on that pregnancy piece. Like, to the extent that there is a literature on women and substance use, it is really, really strongly focused on the role of substances during pregnancy. And I wonder the extent to which that focus on pregnancy specifically means that in cases of harm reduction, that narrative gets co-opted when we think about how women are served by harm reduction. If we immediately only jump straight to harm reduction in the context of pregnancy, people have a very different reaction to that line of work than they would if it were kind of just a broader conversation about harm reduction. Thank you very much. So Kiana, if you can round us out here, thinking about, again, given your expertise, and as you said, your many, many hats that you've put on over the years, what do you think are the most pressing gaps at the intersection of women's health and substance use literature?
Yes, and I like how you framed the question, Tyranny, depending on your expertise, because I think how we view gaps in general, right, is from the perspective that we take. And as an epidemiologist, as a public health expert, the general question that informs my research is, how can I help as many people as at once, right? And when I think about that, how to do that, it inherently leads me to environmentally based interventions and interventions that are aimed at improving systems that people interact with, healthcare systems, social service systems. When we improve where people live, their neighborhoods, their communities, their towns, their cities, urban areas, rural areas, we inherently help many of the people who live in those places. And the same with systems, right? When we improve the healthcare systems, I have more likelihood of reaching my goal of helping many people at once, right? But when we use this, let's continue with this prenatal substance use example, right? When we use that as an example, we see that these environmentally based and these system level interventions, that's the area where there's a gap. Because with prenatal substance use, the status quo is that the onus is on the pregnant individual. The onus is on that pregnant person to get treatment. Given that many states have mandatory reporting laws around prenatal substance use, many women are penalized or criminalized if they use substances during pregnancy. Right, treatment is definitely needed. So when the healthcare system works, we facilitate treatment. However, when the same place that's supposed to help me can also criminalize and penalize me, what do I do there? So I think in order to address this gap, we need to focus on a prevention framework broadly, right? But what that might look like is intervening on those things, macro level, system level things that predict or are correlated with or cause prenatal substance use. Let's think about reducing the density of tobacco and alcohol outlets, for example, in residential neighborhoods. Through the research, we know that this is associated with substance use. In light of cannabis legalization, we can borrow from that literature, the tobacco and alcohol literature, and just reduce the availability of cannabis dispensaries in residential areas. What are we talking about at point of sale? We talked about women using cannabis, pregnant individuals using cannabis, Lauren mentioned, because they're self-medicating their mental health symptoms. What's the point of sale message around cannabis if I'm purchasing from a dispensary and I'm pregnant? These are all interventions that we can implement. We see that these things work from the literature, but we don't do that in the sense of prenatal substance use because of the status quo. Practice is really fast. Even in states where there are no mandatory reporting laws around prenatal substance use, there are often voluntary reporting laws, and we're reporting pregnant individuals and not treating them, or trying to do a little bit of both. And we don't take this prevention framework to address the gaps around system level approaches and improving neighborhoods, right? Improving where we live. I need a living wage. I need not so much availability and access to substance use or to substances that I can use that can harm me and my fetus. I need
Yeah.
access to housing, all of that.
Yeah. I think what you're referencing here is a really nice dovetail into our second broader question, which has to do with policy, prevention, intervention implications. And essentially it's a call to arms. What you're referencing here is that, you know, we need to be in this moment more than ever, really focusing on translation to policy, to system level changes based on the literature. Like you said, you know, we know environmental changes, we know harm reduction, we know decriminalization. All of these things have really powerful positive health effects. We need to be able to implement them in context, kind of what Danielle was speaking to. In context, we need to be thinking about the rural context. How does that, you know, how do these systemic level changes need to potentially be modified or altered by context? So to that end, if I can swap us over to our other question, Katie, if you want to lead us through our next breadth question.
Absolutely. I'm hearing some themes come through as well, Kiana, from you on systems level interventions and really identifying those gaps to reach the maximum number of people. Danielle, you've already spoken to translational science and the role of the practitioner, the scientist practitioner, of speaking to the public. And Lauren, you've already focused on these levels of vulnerability being both bottom up and top down. So not only where people are accessing treatment, but acknowledging things like mental health as a core aspect of women's health. And what I keep hearing is the science practitioner role as an advocate for our clients and for our patients, in that scientist practice is not policy agnostic. And that is particularly important to consider given the current politicization of women's bodies, of gender diversity, of substance use, and this role that we've already acknowledged of the scientist in translating our best research into policy that'll reach the most people on the ground. So given all of that, what do you all believe are the most urgent policy, prevention, or intervention implications based on the current findings, based on your areas of expertise in the women's health literature? And I will reverse our order. So Kiana, I would love to hear from you first.
So it's two things that stand out to me with that question. One is a very specific answer, and the other is a more structural issue that will allow us, the collective we that work in the space, to do our job in a renewed way. So to give one example, because I have many, but this is like only an hour, and I have to share the time, right? When we think about treatment for substance use, prenatal substance use particularly, if this treatment is happening at a hospital or clinic, the places we see people in their, white coats and with stethoscopes and things like that, it seems obvious, we can't have the same place that I go for help to be the exact same place that I go to be criminalized or penalized. We need a system. We need systems in place, policies in place at the systems level and at the state level, right? To where treatment and mandatory reporting of prenatal substance use won't be pitted against each other. When we think about just the epidemiology of substance use and the progression of substance use, most people who use substances don't go on to have a substance use disorder, right? So when we think about these mandatory reporting laws, right, we say they criminalize and penalize women, sure they do. But when someone else looking at these laws from a child's health perspective, they may say, no, they protect the child, right? So it's that battle, right? But the nuance there is nurses, social worker, mandatory reporters have to make a judgment of whether or not this pregnant individual's substance use is putting this child or fetus in inherent danger, right? And that's what's missed with this blanket of report people almost automatically, but particularly if you're a person of color. Let's just blanketly report you without deep thought, right? And no judgment. And I don't mean to say that in a harsh way. It's just a matter of fact way, because remember, I've been a nurse on the floor, overwhelmed, right? A social worker, overwhelmed in practice. It moves very quickly. And this leads into my more kind of structural approach to how the collective we in this area could do our work. This notion that I read about all the time of, get out there as an academic, as a scientist, or as a practitioner and advocate and advocate for policy change. It sounds great. I wore many different hats, some of them not at the same time, where I can bring all of my perspectives together at the same time as in research, right? When I was primarily a practitioner, a social worker, I have founded and directed a drug treatment program. I was not conducting research. I was on the ground of research in terms of evaluating my practice, sure, but I was on the ground with my people, like the people I was treating. As a practitioner, as a scientist in the academy on the tenure track, where might I find the time to go meet with the senator and go meet with the local politician? That's not valued in a real way in the tenure and promotion process. So in order for me to be this idea, almost make-believe scientist, practitioner, advocate, superhero, all at once, I need to work within a system that values that in a real way. It's a lot of lip service being given to make change happen. We cannot do that if the thing that is valued is, grants, publications, and teaching. That's fine if we sit at academia, but we have to have, if this is to be done, the structure that facilitates our work has to change. I'm very happy to be on the ground and write the paper, but that's not what's valued in reality. That's only what's talked about, right?
Yeah. I'm hearing two primary themes come through from what you just shared. First being our healthcare workers cannot be collaborating with prosecutors. Like you can't have a healthcare worker who is also in some way a prosecutor or someone who is passing judgment and criminalizing. And the fundamental values of our field need to shift not only toward equity, but beyond the sort of publisher perish, individualized culture of productivity, reputations of the ivory tower, this sort of sterilization of our work for the purpose of professional gain. And I feel both of those things very strongly. So I appreciate you bringing those perspectives to this conversation. And Danielle, I would love to flip up to you. Oh, sorry.
I'm sorry, just one quick point. I want to make clear, we do need to collaborate, right? So collaborate. I need to collaborate with people with different perspectives, be it a prosecutor or a lawyer or whoever. Let's collaborate. But it needs to be what I meant by that comment is I should be able to tell, the collective I, right? The we. I'm not pregnant, nor am I on drugs going to seek healthcare. But you know what I mean? If that population is going to a hospital, I need to know this is the place that I get care. I need to be able to determine if this is a hospital or a jail. If we don't know that is so. But if I can collaborate with actual prosecutors in a real way, with actual politicians in a real way to make things better, sure, let's all come together and talk. But I think often you don't know if you're going to be helped or harmed at hospitals. And remember, I was a practitioner. If I was a nurse in my first career, so I'm not saying this in a, biased, way. It's just from my experience. Thank you.
Yeah, it's unclear if it's a space of care or a space of punishment.
And I think something that I just heard from you, Kiana, that I've not heard in this discussion previously, and it's really kind of giving me some food for thought, is the need for discretion, the need for our whatever system level approach we create to allow for the discretion of the practitioner to make a decision about this individual patient in this context, in this moment. Do I think that this person genuinely is at risk of harm to self and others? That's a decision-making process that we give to our healthcare providers in so many different domains. But again, as soon as you start to enter into this world in which pregnancy is being invoked, we just fundamentally change the nature of that decision-making process. And I feel like we're all feeling that right now.
Yeah.
But again, Katie, thank you for keeping us flowing. And I do want to move us up to Danielle as well for the same question.
I'm sorry, one more point, just to your point, Tyranny. The actual policy, if you read your state policies around mandatory reporting laws regarding prenatal substance use, it actually says we should give this discretion to our mandated reporters. It's the implementation of that policy that goes wild, right? So that's all.
Thank you so much, Kiana. Danielle, what from your perspective and in your area of expertise are the most urgent policy, prevention, or intervention implications in women's health at this moment?
Well, Kiana just brought up so many things that is going to probably change my answer. And I haven't thought this through, so it may not be eloquent, but hearing all of the talk about, policy, criminalization, and, whether or not the hospital is a safe space or, not, it is tying so closely and bringing me back to some of the research I've done related to screening for intimate partner violence within healthcare settings. And so many of the issues you all are bringing up and that do exist in the substance abuse literature, we have found related to the violence literature as well, and the intersection that women have, coming into the healthcare system as patients. They're entering a system that, in general, if you look at policy and if you look at mandatory reporting and screening and how that is required in many organizations now, on its face, it looks very survivor friendly, right? We are screening because we can help if we screen. If we don't know, how can we help? And Kiana, your point is just so well taken, that even if all of our intentions are in the right place with that, the way it's actually being implemented, because we are this very complicated system that nobody is a superhero in, at least when it comes to the screening part, in my world, it's not working. We are not only not helping, there are some cases where folks can report feeling harmed by some screening practices and policies. And with some of the work we've done in West Virginia, we've really tried to bring survivors together and different stakeholders together, and almost reevaluate what they might want in terms of outcomes of screening. And so I'm thinking of how that might apply to thinking of, let's say, patients that are seeking a treatment for substance use, maybe with a little bit of the medical model, maybe even with some evidence that we have. It's very driven by what research has said is effective, right? Or should be what we're looking at. And when we talked with survivors about what they want to see in the healthcare system, what outcomes matter to them, they could not have been more different than what the research has focused on for 30 years. And so if you look at outcomes from screening that researchers have measured for 20 years, 30 years, it is, if we screen, can violence be reduced? Can a person leave their violent relationship? Does their physical or mental health improve? And as we talked to survivors, it became very clear very quickly that those were completely lofty and not realistic outcomes that we, as a just research healthcare system, would be able to influence with such a simple intervention as asking, are you safe at home? Right? Within, in a context of a 15-minute very busy visit. And so instead, what we heard from them is, well, you're asking us what we want as a result of screening. We want to feel like we have a safe space if we ever need to come back here. We want to feel not judged. We want to feel respected. And we want to feel like we are in charge of our own lives, that it's our decision, and not that if I tell someone this thing, that they are going to have to report to someone that I'm in this situation. And it's just that gap between what we're focusing on in the field and what survivors have said that matters to them. It just blows my mind every time I think about it. And when I compare those two things, I say to myself, the outcomes that the survivors want are so realistic to achieve within a healthcare setting. That's just good patient care. They want good patient care and good bedside manner and things that no healthcare provider would say isn't realistic. But the healthcare providers we worked with did tell us how daunting it was to feel like they had to single-handedly, in the course of a 15-minute visit, change the course of their patient's life if they disclosed that they were in an abusive relationship, or there was a combination of violence and substance use as well. And so I feel like when we started to see and unravel those outcomes that matter to survivors and were informed by stakeholders, it was almost a collective like breath of relief. Like, oh, we can do that. And so I have certainly driven into the patient-centered world, and that's sort of where I live in terms of where we can move forward, right? Where are the gaps? The gaps are in, we need to take off our research hats maybe and talk to the people that are actually on the ground in the real world doing the work and asking what works for them and what doesn't work for them and what they want. And I think we would get a lot further. So.
Absolutely. Danielle, I think you're speaking to this sort of runaway train of like academic goals where we can be on a singular track. And Kiana, it speaks to what you were talking about earlier of these reputational priorities, the publisher parish urgency, each of our individual careers really taking precedence. And that 20 to 30 years of this is what the literature has been discussing in this time is more or less the life cycle of an academic. So you'll have a generation of scholars coming into a space deciding to prioritize a topic that may be very far from the goals of our patients or clients themselves, and then dedicating their career, these 20 to 30 years of very important labor, to something that is so distal from what our clients and our patients actually need. Thank both of you so much for bringing up these perspectives. And Lauren, I'll pass the last breath question over to you, which from your perspective and with your expertise, what are the most urgent policy, prevention, or intervention implications based on current findings in the women's health literature to date?
Katie and Kiana and Danielle, I appreciate everything that you said, and I agree with every single word that you uttered. And I, will just add to what you said as best I can, but really just echoing your sentiments, which first, Danielle, I completely agree that co-creating prevention, sort of like topic agnostic, right? Like, are we talking, it doesn't matter what we're talking about. We have to co-create prevention efforts and interventions with the target population. It's a top-down approach, which I think has been, sort of the status quo for some time. It's just not going to work how we want it to. And our endpoints are likely, or potentially, but in my space, often quite different from the desired endpoints of the population. I'm a developmental psychologist. I study prenatal substance use, and there's this tendency to prioritize baby's health over mom's health. And when we do that, our endpoints are related to baby, but maternal endpoint is, maybe that, but there's like several harm reduction endpoints along the way that are more important to mom and are really, more necessary and relevant and pertinent and perhaps achievable for pregnant people than just, straight abstinence, like immediate abstinence. We have to have open dialogue with our populations. Absolutely, no question. And just, I'll keep us in the prenatal substance use space. And I think this conversation has largely, been focused there so far. And I will keep us there because that's the space that I know best and am most passionate about. But these laws that Kiana has referenced, where you have mandated reporting, punitive policies generally, right? It's like criminalization in addition to mandated reporting. Not only they don't work. They actually don't. There's like loads of data that suggests that they don't achieve their intended objectives. So in states where we have punitive prenatal substance use laws, pregnant people are less likely to seek prenatal care. They're not surprisingly less likely to disclose their substance use to the provider. The provider is less likely to ask about it because they care for their patient and they don't want to have to report them either. And so if we're setting up a system where we can't have an open dialogue, then that's a failure for everybody. And to your point, Kiana, it's a great one that we're actually exacerbating racial and socioeconomic health disparities in these punitive policies. Black and brown families are less likely to be reunited with their children after, Black and brown families are more likely to be reported to CPS for prenatal substance use. And then following report, they're less likely to be reunited with their children. And I could talk on that point forever, but we need to rethink this this sort of necessary separation between those who are supposed to take care of us and those that are required to harm us.
Absolutely.
If I can I'm sorry, go ahead, Katie.
Go for it.
Just perfect points, Lauren. I want to add one thing. When we talk about Black and brown families being reported more often, it's even when there's no difference in substance use between Black, brown, and white families, right? Because people can run with that data to say, well, maybe they're using more, even when there's no difference in substance use. They're reported more. That's where the inequity comes in at, right?
Thank you for clarifying. That's an incredibly important point. Yes, absolutely, right. So these rates are not necessarily higher in these minoritized populations, but rather they're more likely to be tested. So even data that suggests that they're more common are actually, flawed from the start.
And Lauren and Danielle, something that I heard both of y'all speak to in your responses is this idea of potential touch points of intervention that really limit this like enormity of provider goals, where we don't have to be fixing or saving clients or patients' lives when they come into the room. We have many smaller opportunities for humanization, whether that's using clinical judgment and deciding not to report, or interrogating our own biases in the space and making sure we are humanizing all of our clients evenly, or every visit we have giving them agency of choice of what do they want to do moving forward in their care. And I really think that coalesces the three of your answers. So thank you so much for your responses to the breadth questions. And Tierney, I will pass it back to you for depth question one.
I'm just sitting here musing about what everyone is saying about, it's sort of classic principal agent problems, right? That we have the funders that have a certain set of priorities, and those priorities are set at one level. And I think it's probably correct to say that the funders who fund work in substance use research, their priorities are to reduce substance use, just overall. And what the literature consistently says is, if that is your goal, the way that you do that is by working with, not against, the users, at the population of users. And I think that fundamental friction is true in the broader substance use world, but it's particularly true the more that you get into some of the more even more stigmatized and minoritized populations, like women of color or pregnant people or so on. So we also have some depth questions we've asked our panelists to think about. We gave them a variety of different possible directions to take the conversation. So we're going to switch into that, although I do want to acknowledge we have one question from the Q&A box. Thank you to our attendees who are using the Q&A box. I encourage everybody to do so. We have Liliani Cervantes, who is asking us to consider the ways in which transgender patients might be included in this conversation in our responses here, thinking about how these factors play out, how the things that we're talking about play out in the context of transgender patients. So I'm going to add that to our overall flavor here. So both Lauren and Kiana, the two of you had identified as the topic that you wanted to go into is thinking about more about measurement, about design, about study design, thinking about how we can better design studies to really center women's health in substance use research, particularly the ways in which healthcare access, the interaction between healthcare access and substance use for women and gender diverse people. Thinking about what are some of the best practices for recruitment, retention, and something that I'm really interested in as someone who's interested in methodology is, what are the teams or the researchers who you think are really doing this right, and who could serve as a role model, if you can think of any of those. So I'll leave that open to, I'll start off with Lauren, and Keanu, you also identified this, so you can jump in kind of where it makes sense.
Sure, thank you. I'll take a stab at this first. There's no question that access to healthcare plays perhaps the most critical role in shaping substance use trajectories, and therefore it's really essential that we explore how barriers to care, things like lack of affordable healthcare stigma, provider knowledge, impact substance use and treatment outcomes. We're doing quite a lot of work, both on the patient side, but also on the provider side, to try and, sort of like break down that stigma and make these, relevant to our conversation before, make, healthcare, especially perinatal healthcare spaces, but really all women's healthcare spaces stigma-free and open, and allow for open dialogue and honest conversation, which is how we best can treat and facilitate the health and well-being of women. To just methods, things that I'm thinking about more in my research lately is that any study I'm doing on substance use in pregnancy is a mixed method study now, like period, full stop. I'm new to the qualitative space, so honestly, it's quite, I've been learning a lot. There's a lot to learn, but sort of starting by asking the questions, and this is all in line with what we've been talking about, but we can't just jump in with a quantitative measure that we've created that we think assesses what we think it assesses, and sort of forcing this on folks. I really think that from the ground up, we need the qualitative piece. And we're also, mixed methods too, in terms of we're assessing substance use in women, specifically in pregnancy in our studies, in real time and ecologically valid methods. So understanding the contexts in which people use substances, and that's essential information for understanding, what sort of motives and contexts maintain or sort of like encourage and also protect pregnant people specifically, but sort of more broadly as they use substances. So just thinking about, like, this is not a problem that we can attack unidirectionally. I think it's something that we need to be thinking about creatively, community-based participatory research, and with mixed methods to really understand sort of like the breadth of what the conversation even needs to be. I'll leave it at that.
Shout out to students here. As someone who started in a much more psychophys oriented and wet lab and kind of bio oriented direction, and has gradually, with the presence of students like Katie in my lab, has just, my eyes have been completely open to the value of mixed methods work and qualitative work, just to be able to fully understand the nature of the questions that we're asking. And kind of to Danielle's point earlier about when we actually ask our participants, well, what do you think should be the goal here? Boy, does that open your eyes to the things that from, and again, purely from the scientist's perspective, your participants are able to identify factors that you're not even thinking of asking about. And those mixed methods are just absolutely critical for being able to capture that. And Kiana.
I totally agree with what Lauren said and your follow-up, Tyranny. The people we are called to serve in this work, they have to be at the table. All right. From, in my perspective, from beginning to end, from research question to the implementation of any type of intervention to interpretation of the results. I commend Danielle and other researchers that spend a lot of time in a qualitative space, right? In order to bring people at the table, particularly for quantitative researchers, you got to share the power, right? You have to share the power, and at the same time, speak truth to power at the institutions you're at. If I'm going to be of service to the people that I'm called to serve, that I should be honored to serve, I should know that it's a true partnership. And that's just not the reality of who the collective we think we are relative to the people we serve. We have to share the power and recognize that they should hold more. We should be directed by community needs, and our research should be of service to those who need it, right? But in order to do that, even if that's the intention of our hearts, and that's what we dreamt up that our career would be, many of us find ourselves in a system where the time, again, we're almost being asked to be superheroes. Do you know how long it takes to develop community partnerships? Do you know how long it takes to go from I can sit at my desk and analyze large data sets. Nobody would be the wiser that I didn't ask a community member anything about this, to shifting to I want the community to be at the table. If you didn't already do that, if you don't already do that, that's a wild shift. You would need retraining The time it takes just to develop true partnership is effort. To have the community to trust you enough. Do you think you're going to walk into any community, particularly a historically marginalized community, and just say, hey, I want you at my table, help me design my study, and everybody, I trust you since you have some knowledge. I'm going to do that now. That's not the way it works. The time it takes to actually do that on a large scale and make that the status quo, we need to rethink the systems in which we work. That's the reality. Even for me, from a practice, if I can give a practice example, when I started my substance use treatment center for women in Baltimore, I worked in a Black community. I'm a Black woman. It's a substance use treatment for pregnant individuals, for women and pregnant people. The community said, who are you and why are you here? I still had to work to build trust. I named the center after my mother, who suffered from substance use on and off through her life. Jane's House of Inspiration. They said, are you Jane? And I said, no, I'm not Jane. We want to see Jane, but you didn't even know me, and you don't want to see me. You want to see Jane. I too want to see Jane, but that's not possible anymore. You have to work to build relationship. They didn't care about my CV. They didn't care that I was at the best school of public health. They didn't care about any of that. To hit the community eyes until I built an authentic relationship with them, I was not qualified. And it was no degree that was going to change their mind. That took work. And services were free. Right? It took work and it took vulnerability. And that takes time. And our day jobs, like I did this work in addition to my day job, right? So our day job doesn't typically allow for that type of work, right? So if we want to do that work in the same place we receive a paycheck from, we have to change the system. And that's a risk, right? If you have to change the system at the same time you work within that system, you might be the one that's expendable to that system, but you might pave the way and make it better for people coming after you. So the question becomes, how much risk are you willing to take? It can be done, but someone has to blaze the trail. And the trailblazers typically don't reap the reward. So is that you? Or are you waiting for someone else to light the torch?
Yeah, this is related. It's not exactly what you're saying here, Kiana, but it highlights for me, I work a great deal with folks who do measurement design and develop, new apps and new sensors and biosensors and things like that. And there's moments when you work with folks like that where you have to remind them, like, there's no app, we're not going to app our way out of this, right? We're not going to psychometrics our way out of this. If we're genuinely trying to embed ourselves into communities and think about the ways in which community access and healthcare access drives the phenomenon that we're interested in, it's not about better measurement design. It's about, as you're saying, potentially changing the institution of scientific research in ways that are going to better align with the needs of the communities, the needs of the researchers, the needs of those who are actually in that partnership. We have just 5 minutes left here on the panel. So I do want to take a moment to remind the chat that if you have not had a chance to put your questions into the Q&A box, we do encourage you to do so. And we are monitoring those. We've had just the one, so please encourage folks to use the Q&A. And we'll end with our last depth question here, which Danielle had identified. So this is a question that is thinking about moving away from a male standard. So historically, women's health research has been seen as an extension of men's health research, right? So finding all the ways in which women differ from men, right? But there's been some increasing recognition and calls in the health research literature to look at women and gender diverse people as people in and of their own rights. I know, what a concept. And rather than constantly comparing everything back to men, instead thinking about how do we center our science and really think about women and women's health at that center, and what would it look like if we actually had a science that centered women's health research. So Danielle, would love to end on your thoughts for that question.
Sure. So my response that I had kind of thought of really mirrored almost everything that Kiana said. I mean, you even had some words that you said that I was going to talk about. So really, I can just kind of add on to that, because I feel like this question that talked about what would that science look like was sort of in line with the first one about like, what can we do methodologically to do better, right? And then what would the outcome look like if we designed studies to take into account everything you all mentioned? And as you were talking, it struck me that we have, over the last, I don't know, 20 years, made strides in looking at systems change and engaging partners in the community and listening to their needs. But it struck me when you were talking, I thought, well, where have we changed the systems? Like in terms of the substance abuse world and violence prevention world, who does the educating of our young people to teach them, where do they develop their norms? Teachers are predominantly women. Who is doing the screening in a healthcare setting? It is usually not the physician. It's a medical assistant, right? Sometimes it's a nurse, and they may be more likely to be women. And are we just sort of shifting the work to give women more work to solve the problems that we are having? And if we truly did center, right, the people, the patients who we're talking about. And I like what you said, Lauren, about just every issue, every topic. It doesn't have to just be this one. Would we pick to put the onus of screening on that medical assistant? Would we ask teachers to literally be every single thing to children and to families? I mean, I don't think we would if we could dream big and do something that was I don't know, if we had more resources, and more an open mind about what it could look like, right? But I feel like we're operating within the systems we have that we know are disproportionately maybe burdening women and burdening some gender diverse folks. And our solutions are then within that, right? Instead of opening it up. So I feel like everything we've said related to kind of burning it all down and starting from scratch in terms of what our notions are about research and what that science could look like. We've just continued kind of down the same path instead of saying maybe science can be different. And Kiana, you are right on the money. We can't do this currently in academia the way it is structured. You cannot get tenure by doing qualitative research, at least in my world, primarily because the publications aren't going to come out for you fast enough, right? The grants are not going to fund your only qualitative thing, right? It's got to be much more quantitative, at least oriented. And so I feel like that's slowly getting better too, but we have a ways to go there. So yeah, that's kind of just what came to mind for me. Thank you.
That is a gorgeous and hopeful note for us to be able to wrap up here. And I want to add, this panel is happening in a much broader context today. And as I was saying to all of our panelists before we started here, the labor of being in research on a stigmatized field, on a stigmatized people, the labor of being a woman or a gender diverse person who studies women and gender diverse people, when the broader social and political context is a moving target at best, that does draw from our own energies as well. And I think that if we're burning it all down and creating a new system, a system that recognizes and rewards and honors that as well. is absolutely critical. So I want to thank everybody here for giving of yourselves in that way, giving of yourselves your perspective. Thank you, everybody, to all of our attendees. As a reminder, we do have symposium activities that will continue through the rest of today and Thursday. The next thing on our agenda, I believe, is our short research presentations, which will be starting at 1 p.m. Central, 2 p.m. Eastern. We have some incredible short presentations, large involvement of students. And so we really want to encourage that next generation of researchers as well. So thank you again to all of our panelists. Thank you so much for your time. And we look forward to having you at our next set of sessions a little bit later on today. Thank you all so very much.